So you can see from the title, Mort always gives me the most unusual titles to discuss, but I think this time it may be somewhat relevant, but let's get underway. So here's a picture of Dr. Altman, and as I mentioned already, I met him for the first time in 1993 at the Lugano meeting, and I found him also a very warm and charming man with a huge amount of knowledge about this field. I would say to Mrs. Altman that one of the things I think he was probably the biggest advocate for is a marriage of clinical medicine to being married together with cancer research or science. And I'd like to think that I actually sort of took that to heart as well, as I kind of modeled my career after that. You may be somewhat surprised that when I first started in about 1987, 88, the head of the department that hired me said, I don't care if you ever publish a paper, Randy, as long as you're good at looking at lymphoma. And I'm happy to report that I looked more or took a little bit of advantage of Dr. Altman's comments, and actually now, as mentioned, over 450 papers later, I'm hoping that I'll actually make 500 before I do pack it in. But another point that was mentioned is I am planning to retire in spite of the passion. So I'm very honored to win this award. Just a very brief outline, but I'll go very quickly as I mentioned. I think one of the things that more challenged me with is to, which you can see here, to raise the question of whether second review pathology is relevant in lymphoma. And I'll show you some data that hopefully convince you that that's absolutely the case. And then we'll use a couple of examples of profiling, which I've been involved in, that kind of set the scene for what the future will look like. It would be a combination of very accurate and very precise pathology that's married together with some biologic correlates in an attempt to understand this disease and improve outcomes. So the first slide here is a study that was done. It actually was originally published in 2012 that came from Memorial, and what they did was very simple. They took 6-month block, as you can see, in January to June 2001, and repeated the same thing in 2006. And they asked the question, did the second volume of the WHO improve the ability to make diagnoses in the community? And as you can see, that it really didn't. And in essence, there was roughly a 17% alteration of the diagnoses that were seen by the primary pathologist that actually happened upon review, and didn't really change even with the WHO book that was available. This is another large study that actually came from Nebraska and was published in 2014 in British Journal of Hematology, and again did the same thing with over 1,000 cases. They asked another important question, though, and that had to do with whether there was an impact on therapy. And as you can see, that when you looked at over 1,000 cases, there were approximately 15% of them where there was a major diagnostic change. I guess I have do I have a pointer? I do. And so you can see that here, approximately 15%. But when a hematologist was involved in deciding whether that diagnostic change led to a treatment change, you can see that 90% of those cases, 131 of the 149, there was a treatment change. So there was little doubt that actually second review was relevant. Now, when we turn our attention to T-cell disease, we see this is even more compelling. These are very difficult diagnoses to make, and this is a study led by Anne Lacaste, as you can see, that involved the sites from the NCCN. And they studied 131 cases of T-cell lymphoma to ask a question about the referring center diagnosis in comparison to that was made upon second review by experts. At the end of the day, you can see that there was a discordance of a little over a third of the cases. You can see there were multiple reasons for that. It either had to do with a misinterpretation of actual tests or actual data that existed, or the addition of other tests that informed upon a diagnosis. But at the end of the day, the important thing is that there were, again, an impact on treatment, with roughly 44% of the cases by the review diagnosis having a change in treatment. That even included, if you can believe it or not, some patients who were diagnosed as benign that actually had a malignant disease. And I would argue that that's a compelling, what I would say is a very compelling difference upon the effect on patients. So at the end of the day, one can conclude that a review of your diagnostic biopsy by somebody with expertise in the field is absolutely critical as it relates to patient care for patients with lymphoma. So having established that, we could say a couple of things. Basically, any good cancer center or any good treating physician would never, as you can see, entertain seeing a patient without that biopsy being reviewed. and that what happens at large centers is they invest in and they cultivate diagnostic expertise in lymphoma pathology. That team that Dr. Sen mentioned between the clinician and the pathologist is absolutely important, and that these benefits actually impact the patient journey in a very important way, is that you have to have an accurate diagnosis in which to plan the appropriate therapies. Now, some practical examples are shown here. And I'll just run through a couple of these. Basically, many of these are important, but distinguishing between Hodgkin lymphoma and something that's malignant lymphoma is very important. Obviously, the first one is rather critical, as you don't want to be treating patients with chemotherapy when they have benign disease. You'd be surprised how often that happens. And a number of other examples are shown here. Let's just walk through some. If you looked at this at high power, you could imagine that that's very bad Hodgkin lymphoma. And although it's a tumor that expresses CD30, in fact, it's also uniformly CD20 positive. And so that's a large B-cell lymphoma. And making that distinction from Hodgkin lymphoma is clearly important. Here's another thing we do as lymphoma pathologists. Here's a nasty-looking cancer, and what's important is that it has complete absence of CD20, as it does other markers. But if you know how to apply the right immunohistochemistry, you can determine that this is, in fact, a large B-cell lymphoma. It's just one that has, what you can see, has cytoplasmic kappa, but also is infected by EBV, and as shown on the right here, by HHV8. So important because that distinction, the lack of CD20, will inform a therapeutic choice as well. Making some of these distinctions obviously very important. This is a case of, as you can see here, classic Burkitt, but distinguishing it from those gray zone type cases and distinguishing it from a case here of large cell lymphoma, which has a MYC rearrangement, is obviously critically important. Now let's talk about the other part of this, and that's the tumor profiling very quickly, and I'll use two examples. So this is large B-cell lymphoma. We appreciate this enormous amount of heterogeneity that we see every day when we look down the microscope. It's morphologic, or we characterize these tumors phenotypically that have outcome correlations, and now we're beginning to understand the mutational landscape and the contribution of genetics. And I would argue that we posed this question many years ago, and we continue to, that this isn't one disease, this is several diseases. And by adding the texture of molecular classification, what we do is now refine the classification of these diseases, but we also have an ability now to predict outcome. We can define specific pathway perturbations, and in the end, we can improve prognosis by hopefully recognizing the bad actors. All of this is designed to accomplish this, and that's the goal of precision medicine, which we have fallen a little bit behind in the lymphoid world, but hoping to catch up. I'll remind you that this original Nature paper was 15 years ago now, in which we described cell of origin subtypes, as you can see, and it's taken quite a long time, almost 15 years, to get to a point where we started to appreciate that these molecular subtypes have relevance, and that relevance is both clinical and also biological. And which is shown down here in 2014, we published a validated marker that was mentioned by Dr. Friedberg, the Lymph2CX assay. That's a reliable assay in which to distinguish the two cell of origin subtypes using formalin-fixed material. We subsequently just published now, as you can see down here, this was in JCO about a month ago, in which we took a very large cohort of almost 350 cases of diffuse large B-cell lymphoma treated uniformly with R-CHOP, and showed again that these outcome distinctions make sense, and thus established a reliable tool on which to distinguish the two dominant cell of origin subtypes. Now, this has already been mentioned as well in earlier talks, I think by Dr. Melnick, that there is now a number of papers which have described the mutational landscape of diffuse large B-cell lymphoma. These data have been very critical to our understanding of the fundamental biology. But in addition, if you look at one of those subtypes, the ABC subtypes, and you look at the characteristic mutations that we see in these diseases and the other abnormalities that occur, they begin to inform on logical targeted therapies, which will be the future in these diseases. And those therapies are outlined here, you can see in the red boxes. I think this is absolutely the way the future will go. So I could make an argument that in the near term, once we hear the result of some randomized trials, both the Phoenix trial and the Robust trial that are using this sort of strategy, that we will need some sort of cell of origin filter as an initial first step. I think once we identify accurately the GCB from the ABC, you could then propose doing FISH studies on the GCB. I'm happy to tell you that every one of those cases that have a MYC and BCL2 rearrangement are purely within the GCB category. That's different than the double expressors, which are mostly here. And I can see a future that looks largely like that as it relates to DLBCL. Now, you've already heard about follicular lymphoma from Jonathan, so I won't spend any time describing in this, but I absolutely agree with him that what we need is a robust tool to try to identify the bad actors at the time of diagnosis. And this study was already mentioned by Jonathan. This is the M7 FLIPI. I'll just remind you that what we did is took a randomized trial from the German low-grade study group, and we actually sequenced 74 genes at depth. And then we went into a model building exercise to build a model that was predictive of failure-free survival. And we did that within the randomized trial, and then we validated this in an independent cohort from British Columbia. And at the end of the day, what we were able to do, as mentioned by Jonathan, is identify the roughly 20 to 25% of patients who are going to have a markedly inferior failure-free survival. And so this paper was mentioned by Jonathan. He's the senior author of this effort. And I raised the question. I don't have the answer, but it's testable to actually pose here that the patients who fall on this curve, on these curves, both for, as you can see, for survival, are they the ones that are identified by the M7 FLIPI? I don't know the answer. I could make a guess, but I think it's importantly very testable. And you could well imagine how our treatment algorithms could change, both in terms of clinical trial enrollment, but also identifying the actual therapies up front, if in fact we had a robust tool to pick those people out at the very beginning. So my last slide is really shown here, and I showed the rainbow because I'm hoping that at the end of that rainbow is a pod of success for somebody in the lymphoid area. I guarantee you that, as stated there, that the practice of lymphoma pathology will outlast my career, which is probably going to end in June of 2016. I think that diagnostic expertise is absolutely critical to patients with lymphoid cancers, as they represent the most difficult diagnostic area for the community pathologists. I think, as shown here, improvements in classification will absolutely help us understand the basic biology of these diseases, but ultimately will help us understand the pathway perturbations that need to be targeted. And I charge all of you to hope to be able to help get these discoveries into the clinic that will benefit patients and hopefully allow us to achieve the goal of precision medicine in lymphoid cancer. I thank you for your attention.